So we have to understand how virus multiplies in order to make any drug that acts against it. So virus fuse with human cells and sends the genetic material inside the cell where it undergoes uncoating and offers the genetic material. It is set free and then it multiplies inside the cell. Replication occurs and forms inactive proteins. Once these inactive proteins are activated, then they undergo assembly and maturation, and the mature virus is finally released outside the cell. Okay. So, this is the virus that is sending its genetic material inside the human cell where it fuses with the cell and undergoes replication. This replicated DNA oblique RNA, any genetic material, right, it forms inactive proteins. When these proteins are converted to active proteins, these go and release the mature virus outside the cell. This is the mechanism of viral multiplication. So, which are the various drugs which act as inhibitors of various levels of viral multiplication? The first one are fusion inhibitors. This is enfuvirtide. It inhibits the fusion of virus with the human cell. Then uncoating inhibitors, they include amantadine. Then virus nucleic acid inhibitors include acyclovir, protease inhibitor. These drugs inhibit the activation of protein. Then virus maturation inhibitors, they include tecovirimat, and virus release inhibitors, they include oseltamivir. Okay, these are the various antiviral drugs that are used. Now, what are the fusion inhibitors? These are mainly used as anti-HIV drugs. Enfuvirtide binds with GP41 and fusion of virus with T cell is inhibited. It is mainly given subcutaneously. Then Maraviroc, it binds with CCR5. It is given orally and cannot bind with CD4 cells with the CXCR4. Okay, then ibalizumab, it is a monoclonal antibody against CD4 receptors. It is given intravenously. Now, multiplication of HIV virus is mainly inhibited by fusion inhibitors, reverse transcriptase inhibitors, integrase inhibitors, and protease inhibitors. So, fusion inhibitors, they prevent the fusion of the HIV virus with the cell. Then reverse transcriptase inhibitors, they prevent the formation of the viral genetic material. Then integrase and protease inhibitors, they act over here. The protease inhibitors inhibit the step of conversion of inactive protein into active protein. So these are the various steps for anti-HIV drugs to act. So what are the reverse transcriptase inhibitors? These inhibit the reverse transcriptase enzyme, that is nothing but RNA dependent DNA polymerase. It may be competitive or non-competitive inhibitors, that is nucleotide reverse transcriptase inhibitor or non-nucleotide reverse transcriptase inhibitor. So, the competitive inhibitors include nucleotide or side, that is nucleoside reverse transcriptase inhibitors. The nucleoside RTIs include zidovudine, lamivudine, stavudine, abacavir, didanosine, zalcitabine, and emtricitabine. Okay, and nucleotide reverse transcriptase inhibitor includes tenofovir. Then non-competitive inhibitors, these are nucleotide reverse transcriptase inhibitors. The first generation includes efavirenz, nevirapine, and delavirdine, and the second generation includes rilpivirine, itavirine, and doravirine. Okay, these are the second generation. Now, nucleoside and nucleotide reverse transcriptase inhibitors most of them result in peripheral neuropathy and also acute pancreatitis. They have a maximum risk of peripheral neuropathy. It is mainly seen with stavudine, very, very important. And maximum risk of pancreatitis is also seen with these drugs. Minimum risk of peripheral neuropathy is seen with lamivudine. It is the safest nucleotide reverse transcriptase inhibitor. Minimum risk of pancreatitis is also with lamivudine. Bone marrow suppression is seen with zidovudine, and myocardial infarction, the person is predisposed to myocardial infarction by abacavir, right? Now, non-nucleoside and nucleotide reverse transcriptase inhibitors, these are prone to develop resistance. Okay, hence they are not given as single drugs. They are effective against HIV type 1 only. They are metabolized by the CYP macrosomal enzymes and are prone to drug interactions. Nevirapine, it is used to prevent vertical transmission of HIV from infected mothers to babies. This drug is hepatotoxic and should not be given with other hepatotoxic drugs. The other hepatotoxic drugs include TB drugs like isoniazid and rifampicin. It should never be combined with isoniazid and rifampicin. Now the next one is integrase inhibitors. They can be given orally, and according to the latest guidelines, they are one of the first line drugs of HIV. The first line HART therapy, that is highly effective antiretroviral therapy, includes 2 NRTIs with 1 NNRTI or an integrase inhibitor. Then elvitegravir is combined with cobicistat, which is a CYP3A4 inhibitor. It is used to boost the effect of elvitegravir. Okay, that is cobicistat. It boosts the effect. Now, the fourth classification is the protease inhibitors. These include ritonavir, liponavir, amprenavir, fosamprenavir, atazanavir, squinavir, nelfinavir, and indinavir. These are mainly metabolized by CYP3A4 enzymes. Okay, the strongest protease inhibitor is ritonavir, and ritonavir boosting effect is what we have to understand. That means when ritonavir is given, it boosts the other inhibitor drugs. It causes lipodystrophy syndrome. Okay, it increases glucose and lipids in the serum. It causes insulin resistance and also weight gain. And then ritonavir is the strongest microsomal inhibitor. It is not used as protease inhibitor. It is used in low dose to inhibit microsomal enzymes and to boost the effect of other protease inhibitors except nalfinavir. Okay, nalfinavir, the effect is not boosted by ritonavir. That is why it is not used. Then indinavir, it causes renal stones, hyperbilirubinemia, and also kidney stones, right? And atazanavir, among all the protease inhibitors, it has the minimum risk of causing lipodystrophy syndrome, but it can result in hyperbilirubinemia. That is the drawback of atazanavir. Now, we were talking about HART therapy. It is nothing but highly active antiretroviral therapy. It is started in all patients irrespective of the CD4 count and is given for lifelong. It includes a minimum of 3 drugs belonging to 2 different groups. It can either have 2 NRTIs with 1 NNRTI or 1 integrase inhibitor. We combine zidovudine, lamivudine with nevirapine. This is the commonly used first line regime for HIV. The other preferred regimen is T plus L plus E. Tenofovir, lamivudine, and efavirenz. Okay. So it is mainly used to prevent development of HIV after exposure, that is mainly seen in healthcare workers. It should be started as early as possible after exposure, that is within a maximum limit of 72 hours. All the drugs are given orally. So TLE includes tenofovir, lamivudine with a protease inhibitor. If the protease inhibitor is contraindicated, we go for efavirenz. Now, prevention of vertical transmission, that is nothing but transfer of HIV from mother to baby, is prevented with giving full HART therapy to the mother. Then after the delivery, the baby is given nevirapine alone. Then zidovudine is started. Then anti-influenza drugs. Now let's look at them. There are 3 types. Uncoating inhibitors. The genetic material cannot become free as uncoating is inhibited. These drugs include amantadine and anti-Parkinson drugs. Used only for influenza A is rimantadine. Please remember, rimantadine is used only for influenza A. Then neuraminidase inhibitors. These include virus. So why are these used? The virus after maturation has to leave that cell and infect the other cells, right? Its connection with that cell should be removed so that it can infect the other cell. This is done by neuraminidase enzyme. So if this enzyme is inhibited, the virus remains clumped to that single cell itself and the further infection is prevented. These drugs are oseltamivir, which is given via oral route, zanamivir inhalational, and peramivir given parenterally. These are the drug of choice for bird flu and swine flu. Okay. Now let's look at polymerase inhibitors. These include baloxavir, which inhibits the multiplication of influenza virus, and a single dose of this baloxavir is sufficient for the treatment of influenza. Okay. So that is polymerase inhibitors. With that note, let's now proceed to anti-herpes drugs. Okay. Now, we know that there are different types of herpes virus. The first one we're looking at is HSV type 1, which infects the mucocutaneous regions of the body and also causes herpes encephalitis. Now, HSV2, we know that it affects the genital region, and then varicella zoster virus, it causes chickenpox, and for all of them, the drug of choice is acyclovir. Okay, the drug of choice for all types of herpes virus is acyclovir. Now, acyclovir in the presence of thymidine kinase, it forms acyclovir monophosphate, and again it is converted into acyclovir diphosphate and acyclovir triphosphate. This inhibits the polymerase enzyme. Okay, so acyclovir will be activated in only those cells which are being infected by the virus, as this drug requires the enzyme viral thymidine kinase for its activation. Okay, please remember, this acyclovir acts only on the cells which are infected by the virus. Okay, if mutation occurs in this enzyme, then the virus will obviously become resistant to this drug, because this drug is dependent on viral thymidine kinase, which we have seen helps in the conversion of acyclovir to acyclovir monophosphate, right? If at all there is a mutation in this enzyme, then the virus becomes resistant to acyclovir. Now, acyclovir is short acting and is a nephrotoxic drug. Other drugs which belong to acyclovir group are valacyclovir, pencyclovir and famciclovir. Okay. Now, ganciclovir is the drug of choice for cytomegalovirus. Please remember, ganciclovir also causes number 1, bone marrow depression. So, it shouldn't be combined with zidovudine. This is another drug which causes bone marrow depression, right? So, ganciclovir is a drug of choice for CMV and it should not be combined with zidovudine. Now, when we look at anti-hepatitis drugs, hepatitis A and E are self-limiting, so no antiviral is recommended for these. Only symptomatic treatment is sufficient. But for hepatitis B, the drug of choice is tenofovir, right? If that is not there, then we go for entecavir, okay? So tenofovir is the drug of choice for hepatitis B. Alternate to this, the drugs which can be given orally and are effective against HIV also include lamivudine, emtricitabine and tenofovir, right? If the oral drugs are not effective, interferons should be injected. However, this action would be non-specific and also would be very toxic. Hepatitis C was previously treated with interferon and ribavirin, but the treatment is very toxic. So currently only oral treatment is being given for hepatitis C. So what are these new oral drugs for hepatitis C? Protease inhibitors include all the Previr drugs. What are these? Telaprevir, Simprevir, Boceprevir, Gazuprevir and Paritapravir. And all the NS5A inhibitors, that is Asvir, Elbasvir, Ledipasvir, Daclatasvir, Ombitasvir, Pimrentasvir. And the NS5B inhibitors include Buvir drugs. What are these? Sofosbuvir, Dasabuvir and Beclabuvir.